Good evening, friends. So we are back today.
2 minutes, sir. We'll just give 2-3 minutes to start.
Okay. We can start.
Just a minute more, sir. We have people joining it.
It's like the last call in the airport before gates are closing.
So Vinay, can we start or 7 to?
Yeah, we can start.
Or we are allowing people? Is that what is
Yeah,
happening?
it's the last call before gate closure.
Okay.
We'll keep
Maybe
joining.
Vinay, you let us know. You let us know. Maybe 7:05 we can start then.
Yeah.
Yeah, we can start now, sir.
Yeah. Okay. Good evening, friends. Welcome you back to the GICS Rapid Journal Review. And today we are going to discuss, we are going to review an article which has already been dissected many times after its publication. And here it is, the Mercy trial, the continuous versus intermittent meropenem administration in critically ill patients with sepsis. So the journal will be presented and hosted by the team of intensivists from Apollo Multispeciality Hospital, Kolkata. And we have a panel experts, Dr. Ajit AK and Dr. Pradeep Rangappa from Bangalore. And I am here, Chief Moderator, Dr. Anirban Hum Chaudhary from Delhi. With these words, I hand over to our moderator, Dr. Chandrashish Chakraborty, to take it over and start the presentation.
Thank you very much, Dr. Anirban. So I'm Dr. Chandrashish. I'm one of the senior consultants in critical care at Apollo Hospitals. And to present today's trial, we have our final year DRMB student in critical care, Dr. Sulagna Banerjee. We will discuss today about the Mercy trial, which is, as Dr. Anirban mentioned, comparison between continuous versus intermittent meropenem administration in critically ill patients and who are septic. And this is a randomized control trial. We are basically, we have basically two goals here. One is definitely to understand how a research article needs to be read, particularly in the field of critical care medicine or medicine in general. And the second is because it is also an important part of the examination. In most of the examinations that you undertake, you are given an article to critically appraise. So we should know what are the major things that we should scan through when we go through an article. So with this, I hand over the podium to Sulagna, and I will ask her to continue with the trial. Thank you.
Thank you, sir. Good evening, all the eminent sir. Today we'll discuss about the Mercy trial, which is a randomized control trial published at JAMA at 16 June 2023 based on continuous versus intermediate meropenem administration in critically ill patient with sepsis. These are the objectives of our today discussion. Meropenem is one of the beta-lactam antibiotic, which is a time dependent. Mainly the efficacy depends on time spent above the minimum inhibitory concentration. Prolonged periods below MIC may decrease the efficacy, so there is a high chance of generation of highly resistant organism. There are different pharmacokinetic studies that suggested that prolonged administration time can provide constant serum levels, maximize time above MIC, and potentially improve efficacy of beta-lactam antibiotics. Systemic review and meta-analysis showed that continuous or extended administration may decrease mortality in patients with sepsis. There is also suggestion from the surviving sepsis guideline, though weak recommendation, they suggest that prolonged administration is better over the intermittent administration. From this background, there are the previous studies. It is a meta-analysis and trial sequential analysis of randomized trial based on the prolonged versus intermediate beta-lactam antibiotic administration in the septic shock and the sepsis patient. This study is they included 869 of records, and among them only 13 of the studies are included in the final analysis. And the analysis result showed that the forest plot shows that the hospital mortality between the prolonged and intermittent infusion strategy in sepsis and septic shock patient favors as a trend of improves mortality in the prolonged administration. There are the true study, which is the Abdul study is 2016, and the Angle study, which is 2000, showed a favorable outcome by improved mortality in the continuous infusion group, a prolonged infusion group, but the study population is very low, so we require a larger study for this. Regarding the attainment of target plasma concentration, it always favors for the prolonged infusion. It is a forest plot and showing that the favors the prolonged infusion. And regarding the clinical cure, it also favors the prolonged infusion. But regarding the adverse drug reactions and the occurrence of antibiotic resistance bacteria, there is no difference between the prolonged and intermittent group. After this meta-analysis, they give the recommendation about hospital mortality between the continuous and the intermittent infusion. It is a low grade of evidence and moderate evidence for the attainment of target plasma concentration and adverse event, and clinical cure and antibiotic resistant bacteria. It is a very low evidence. From this background, we go for this Mercy trial. It is an international multi-center double-blinded randomized control trial, and there is very few suitably powered double-blinded RCTs are there. So it is a trial of relevance. It is the study question was, does continuous administration of meropenem reduce a composite of mortality and emergence drug resistant bacteria among critically ill patients with sepsis compared to with intermittent administration? Study design. The design of the study is a multi-center double-blinded RCT with 1:1 allocation at 31 ICU of 26 hospitals in 4 countries: Croatia, Italy, Kazakhstan, and Russia. The eligible patients are aged more than equal to 18 years, admitted to ICU, requiring antibiotic therapy with meropenem as per decision of the clinician having sepsis or septic shock. Regarding the randomization, the physician selected a web-based centralized randomization study. A randomization list was created with the use of computer-generated permuted block sequence. The patients, physician, and study investigator were blinded to the treatment allocation. After the allocation, the phone call was done to the treating nurse and the pharmacist. They only know that who are treated with meropenem and who are not. Inclusion criteria is same.
Shulagna, if I can stop you here, just go back to the previous. Yeah. So just from the study design, what is your comment about the study? Do you think what is the yeah?
Sir, the external validity is very good because it is a multi-center, double-blinded, and includes 4 countries. So the external validity is very good for this study, and the randomization is also good. Not only the blinding, they also use a double dummy technique so that the patients who are getting meropenem and who are not getting meropenem, though both are given a 50cc syringe pump with one is with drug and another is a meropenem. So regarding the randomization and the external validity of the study is very good.
Okay, carry on.
Is the inclusion criteria. Regarding the definition, the sepsis is defined by the study as a systemic inflammatory response syndrome plus suspected or documented infection plus sequential organ failure assessment score more than equal to 2. And the septic shock is a sepsis definition plus persistent hypotension requiring vasopressin to maintain a mean arterial pressure more than equal to 65 millimeter of mercury and a serum lactate more than 2 millimole per liter despite adequate resuscitation, and the patient who can able to give the consent. Exclusion criteria includes the patient is excluded even at least one of the criteria is present, unable to express consent or refusing to provide consent, already receiving the study drug or other carbapenem both as a bolus or continuous infusion, known allergy or intolerance to the study drug, other carbapenem, or severe allergic reaction to beta-lactam antibiotic or to anhydrous sodium carbonate, which is a salt form of the meropenem which is commercially available. For low chance of survival where the SAP score is more than 65, concomitant acquired immunodeficiency syndrome stage 3 according to CDC, and immunosuppression anything or long-term steroid therapy more than 0.5 milligram per kg per day for over 30 days. It is the consort diagram of we split it in 2 parts for better visualization. Total 896 adults were admitted in the intensive care and 289 excluded as per the exclusion criteria, and 607 patients are in for randomization. In the randomization, the 303 patients are randomized to receive continuous administration. Among them, 1 is crossover, the total 302, and 304 a patient randomized to the intermittent group. Among the 303 in the continuous infusion group, 279 made the protocol, and so that they are taken into account for statistical analysis. There is a after randomization, there is a exclusion, so the trial design go for a modified intention to treat approach. The study intervention: after collection of suitable culture specimen, patients were randomized to receive continuous administration of meropenem as a dose of 3 gram over 24 hours or intermittent administration like 30 to 60 minutes of equal dose that was divided into 3 daily doses. Before administration of loading dose, blood samples and the suspected sites culture specimen were obtained. The respiratory cultures included distal protected sample bronchoalveolar lavage. 3 samples of blood culture were obtained with at least 1 sample not drawn from indwelling intravascular catheter. To maintain the blinding, each patient experienced both types of administration method using double dummy technique according to the randomization group assignment, in which one of the 2 administration method was placebo 0.9% NS and other was a study drug which is a meropenem. It is a drug administration method. The bolus group, when the creatinine. Yes, sir.
What was your interpretation from the second part of the consort diagram that you showed? This one.
Sir, It is a 896 is the total patient, and then 607 are allocated, so that in the between there is a large 289, almost 1/3 patients are excluded. So the patient has a large amount of patients which got excluded, so it may hamper the study results and outcome.
But the patients who are finally randomized,
Hmm.
were they actually followed to the end of the study?
Among them, said 279 made the protocol among the 303, and 304, and they are included following the protocol. The 303 for the continuous group and 304 in the intermittent group. In the 303
So after
group,
randomization, you don't have a lot of loss, right?
exactly.
The percentage loss is less than 10%.
Yes.
Okay. So that shows that the trial has been well done, right? After randomization.
Right. Adherence of the study protocol is good.
Carry on. Yeah, this is done.
It is the drug administration method for the creatinine clearance when it is more than 50 ml per minute, 1 gram every 6 hours for first 24 hours, and then every 8 hours after. And if creatinine clearance is less than 50 ml per minute, 1 gram every 8 hours on first 24 hours, then every 12 hours intermittent. Then continuous infusion group, the drug is given, the patient randomized to continuous infusion group where the creatinine clearance when more than 50, 3 gram per day, and when it is less than 50, it is a 2 gram per day. Dose was adjusted as per creatinine clearance, and not only that, if there is a special circumstances like the suspected meningitis or the patient with high MIC, the dose can be doubled as per clinician judgment. And the study assessment continued up to 28 days after administration of first bolus drug, and duration and interpretations were all about the clinical judgment of the treating physician. Antibiotic stopping criteria for the patient with microbiologically confirmed diagnosis, like for Pseudomonas aeruginosa, that we consider 15 days treatment. For any pathogen with MIC more than 1 and less than 2, consider at least 15 days treatment, and the patient who has a MIC less than 1, consider stopping antibiotic after 8 to 10 days. The antibiotic for the without microbiologically confirmed diagnosis, consider at least 8 days of treatment. Consider stopping antibiotics after 40 to 72 hours after with core temperature less than 38.4 degrees Celsius, neutrophil leukocytosis reduced, or for pneumonia where FiO2 requirement less than 40%. A blinded investigator performed the telephone follow-up with the patients or the caregiver at 28 days and 90 days from randomization, focusing on readmissions and survival. If follow-up was unsuccessful, contact was made with patient's general practitioner, the local office, or through the letter sent to the home address. If the patient died before consent, data can be also collected if the local society allowed. The data and the study management, the parameters taken includes baseline characters, comorbidity, vital signs, history of previous administration antibiotics, SAPS-2 score, SOFA score, GCS, mechanical ventilation status and settings, urine output, and site of infection. The total duration of the study is from the 5th June 2018 to 9th August 2022. The study population, total 607 patients were randomized, 303 to the continuous group and 304 to the intermittent administration group. The objectives of the study, the primary goal was to assess the composite all-cause mortality and emergence of pan-drug resistant or extensively drug-resistant bacteria at day 28. Pan-drug resistant means it is resistant to all type of antibiotics, and extensively resistant showing the only one antibiotic in 2 or less group, where it is commonly sensitive. The predefined secondary outcomes included days alive or free from antibiotics at day 28, days alive and free from the ICU at day 28, all-cause mortality at day 90, and cumulative SOFA score at day 28. The statistical analysis, the hypothesis was that the primary outcome would occur in 52% of the patient in the intermediate administration group, and continuous infusion would lead to an absolute reduction of it is 12%. The sample size of 300 patients per group would achieve greater than 80% power to detect a study with the difference at an alpha level of 0.05. Three planned interim analysis was done at the 150, 300, and 450 patients. Statistical analysis, the composite primary outcome was analysis using two-tailed chi-square based on the intention to treat approach, because it also assesses the right-sided tailed and the left-sided tailed, two types of chi-square for better accuracy of the study. For continuous variables with non-parametric distribution, the data are expressed as median and interquartile range, and the man-Whitney's test was used to compare the outcomes. Data are also analyzed using per protocol analysis based on modified intention to treat principle in patients with MDR bacteria but sensitive to meropenem. Data were stored electronically and analyzed using software V16, and a two-sided p-value less than 0.05 was used as a statistical significant threshold. This is the baseline characteristic chart. We see the star marks that the antibiotic therapy within 3 months before randomization in the 67% patient in the continuous group and 65% patient in the intermediate group, but the no specification found what type of antibiotic was given to this patient. No site of infection is found in the 70% patient in the continuous group and the 64% patient in the intermediate group. The median time from hospital admission to randomization is 9 days for the continuous group and 8 days for the intermittent group. The time from intensive care ICU admission to randomization is 5 days in continuous group, and both in intermittent group is also 5. And the 62% patient in continuous administration group presented with septic shock with a median SOFA score of 9, and the 60% of intermediate administration group had a septic shock with a median SOFA score was also 9. Both are regarding the concurrent antibiotic treatment and types of pathogen, before randomization, the 443 patient, almost 74% received additional antibiotics other than meropenem. The glycopeptide were the most common additional antibiotic, but in 28% in continuous administration group and 30% of the patient in intermediate administration group, a causative organism was never identified. Most frequently isolated organisms were Klebsiella, Pseudomonas, and E. coli. For the better visualization, we split it into 3 parts. The first is the non-susceptible to carbapenem antibiotic. The organism found 35% in the continuous group and the 30% in the intermittent group. And these are the following: 2 gram per day is 24% in the continuous and 28% in the intermediate group. Meropenem daily dose in the continuous and the intermediate group is same, and overall duration is also median duration is 11 days in both continuous and the intermittent group, and in the patient who survived to 28 days, both has the same median duration of antibiotic therapy.
So Sulabna, can we say here that approximately 30% patients were being treated with carbapenem, but they were not susceptible to that?
Yes.
And another 30% is a culture negative sepsis, so we don't know what was the mechanism, right? So that is more than 50% of the total patients. Well, if we put together.
Exactly, sir.
Okay, so we can carry on from here.
It is the most common type of other antibiotics, and their percentage between the continuous and intermediate group. We see that glycopeptide is the most common, almost 30% in continuous and the 28% in the intermediate group, and all the other parameters are almost similar in both groups. The commonly diagnosed and organisms are gram-negative, gram-positive. Gram-negatives are Klebsiella, Pseudomonas, and E. coli, the top three, and the gram-positive in the coagulase-negative Staph aureus, and Enterococcus faecium in the top three groups. Polymicrobial infection by gram-negative organism is the 20% in continuous group and 17% in the intermittent group, and both gram-negative and gram-positive poly-infection is the 22% in the continuous group and 15% in the intermediate group. And it is also significant that unidentified group is a 28% in case of continuous group, and intermediate group is almost 30%. And it is a result chart which showing that the primary outcome, there is 47% occurrence of the primary composite outcome in the continuous group and 49% in the intermediate group. And when we split the composite outcome in two parts, all cause mortality at 28 days, it is 30% in case of continuous group and 33% in the intermittent group. And emergence of pan-drug resistance or extensively drug resistant bacteria at 28 days is 24% in continuous group and 25% in the intermediate group. And the secondary outcomes is also similar in both group. 90 days mortality, alive or free from antibiotic at 28 days, and alive and free from ICU care, all are similar in those cases, and p-values are 0.9, 0.5 and 0.4. Post-hoc analysis was also done, and they are based on the expressed at interquartile range, and says that the length of intensive care unit stay among those patients who survive 28 days, or length of hospital stay among those who survive to 28 days, and readmission, all are similar. There is no significant difference in both groups. And you also see the Kaplan-Meier curve, and Kaplan-Meier curve also showing no difference in the survival in both group and regarding the primary outcome. And no significant adverse drug reaction is also reported in those two groups. The strength of the study is a microbiologically documented infection up to 50 to 60% patients, rigorous adherence to trial protocol and sending cultures, and double-blinded multicentric large RCTs. Regarding the limitation, they have said, as per the authors, the clinician can increase or decrease the dose of the drug as per the renal function. The study focused mainly on one type of carbapenem, meropenem. It exerts its action initially by bactericidal property, later inhibit the growth at sub-inhibitory concentration. This post-antibiotic effect was found for E. coli, Klebsiella, and Pseudomonas, and range from 0.7 to 2.5 hours, and may be responsible for this type of study outcome. And this study cannot be extrapolated to the other type of beta-lactam, and the TDM, therapeutic drug monitoring, was also not done in this study. Concurrent therapy with other antimicrobial was common and might have offered the protection during the low meropenem concentration period. It might be possible that this study was underpowered to detect a small treatment effect than expected, and they did not collect about the microbiological cure of the baseline infection after randomization. When we review the previous studies, there is a clinical review of this continuous infusion of beta-lactam antibiotic in severe infections by Jason Roberts group, and they conclude that it is mainly useful for the seriously ill patient with severe infections requiring significant antibiotic courses more than 4 days, maybe the subgroup that will achieve better outcomes with continuous infusion group, mainly for the patient who has a highly resistant group where the MIC of the pathogen is more than 4 milligram per liter. That group is maybe beneficial for continuous infusion. Regarding the PKPD consideration, as we see that it is mainly the time over the MIC is very important, because it's a time dependent antibiotic, and the critically ill patients has a multiple factors regarding the alteration of volume of distribution, albumin level, different altered clearance of the drug. So we see that when we give a intermittent, there is a sudden peak and fall, and when we giving a prolonged infusion, then it is above, but with continuous infusion, the steady state above the MIC can be maintained. But there are some problems regarding the continuous infusion regarding the chemical stability of the drug at the ICU temperature, because we see that when it is a native molecule carbapenem, and in the ICU temperature, when it exposed to temperature, and their structural instability is there, so it may alter the efficacy of the drug. It is means the efficacy, but this instability can be modulated by the PENAPs, mainly penicillins and the cephem, but the cephalosporin, but their structural advantages. But it is difficult for carbapenem because the strong tension in the beta-lactam ring induced by the fused 5-member ring and strong electroattracting properties in the C3 side chain. So it is difficult to maintain the clinical thermal stability at the ICU temperature. Here the distribution of the beta-lactam antibiotics in the room, different temperature, and it shows that meropenem at 4 degrees Celsius can only active over 24 hours, but other only penicillin G is on 37 degrees Celsius. It can chemical stable only for less than equal to 6 hours. So that the chemical stability is very difficult for the beta meropenem antibiotic group. Regarding the pros, that it is very easier to use hospital setting, monitoring easy, can help containing help in cutting the cost, and also the steady concentration is maintained most in case of severely resistant organism with high MICs. Regarding the cons, the chemical stability is a very important factor. Compatibility issues, because the co-administration of other drugs may change the chemical structure, so may be difficult in these cases. This motor operated syringe pump availabilities, high serum levels maintained for prolonged period, there is a high chance of toxicity. So we have to take into all this consideration behind the continuous in administration. The pharmacological studies though supported the prolonged infusion attaining the high plasma concentration for resistant pathogen with higher MIC, the delivery of greater exposure to target the higher MIC. Expert opinion supported that continuous infusion of beta-lactams, highlighting the PKPD advantages of continuous infusion, feasibility of the technique, benefit for resistant pathogen. Unlike previous studies enrolling patients, they are early stage of sepsis. Most patients in our study in hospital-acquired sepsis, so having poor prognosis with limited modifiable clinical course as compared to community-acquired sepsis. So from this study, we conclude that in a critically ill patients with sepsis compared with intermediate administration, the continuous administration of meropenem didn't improve the composite outcome of mortality and emergence of pan-drug resistant or extensive drug resistant bacteria at day 28. But there is something of discussion regarding this study that both in hospital-acquired and community-acquired infection, patient got meropenem empirically. Resistant pattern and susceptibility may vary in those groups. Antibiotic structural stability at ICU temperature is inconsistent. 67% of continuous infusion group and 65% of intermittent administration group received antibiotic within last 90 days. That may interfere the resistance pattern of the antimicrobial. Median time of to administration of antimicrobial to admission is 99 days. In case of septic shock patients, such prolonged time may affect the outcome. A proportion of patients in both continuous and intermittent administration group, no organisms were isolated. Sepsis mimic condition may be the cause of admission. That's why the outcome may be same in both groups. 35% of continuous and 30% of intermediate group had carbapenem resistant organism. That's why outcome might not vary in both groups. Cost and logistic issues to be considered, and effect of the RRT, if any, not mentioned in the study. Composite outcome problems, because one outcome may not be related to other, so that's the problem in these study groups. So there are some upcoming large multi-standing trial, which is a BLINK-3 trial by Jeffrey Lippman group, who are taking the patient samples and it showing that we can highlight the further.
Thank you. Thank you very much, Shilagna. Excellent presentation. You have nicely elaborated the findings that the investigators have come out from the study. And once again, we are going to dissect this trial, which apparently is such a nice trial, performed excellently, and yet has some setbacks in the form of shortcomings. First and foremost, we have our panelists, Dr. Pradeep and Dr. Ajit. Pradeep, I wish to know from you that in this trial, they have taken a composite outcome of resistance and mortality at 28 days, which in fact is different from mortality at 28 days alone. So this study, despite being powered to detect for a primary composite outcome of resistance and mortality at 28 days, is still underpowered to detect the mortality at 28 days alone. So what do you comment on this?
Yeah, I think that's a very pertinent question. So, as Sulagna mentioned, thanks, Nirban. I wish to congratulate Sulagna for a very excellent and exhaustive presentation. In fact, I was noting that she has gone beyond that manuscript and looked into a lot of information. Very good, Sulagna. So, as you rightly said, in fact, even in the manuscript, authors do mention that this possibly is a limitation to some extent that they have looked at a composite endpoint. And as it was discussed, and Chandrashi did ask that around 35%, approximately 28 and 30% were culture negative. So, which means we do not have information, they relied only on cultures. So we aren't sure. We discussed this in our internal group as to why there were other methods like multiplex PCR and other methods not put in place to recognize the resistance pattern. Because now you have so excellent tools like CARBAR and so on and so forth to detect. So all this may have led to skewing of the results and may have undermined or overwhelmed the primary endpoints. So,
Fine.
looking at a composite, I think that was the problem there.
We will discuss those. We will take up one by one issue. So this is certainly one important point that which you have mentioned, that composite outcome needs to be understood and needs to be interpreted in the proper sense of the term. Chandrashish, in this study, we know that this study was carried out in 4 countries where people are also on the heavier side. And yet the dose that we are talking about is 1 gram 8 hourly or a maximum of 3 grams, which is again reduced to 2 grams in those with creatinine clearance, according to the Cockcroft-Gault formula. Now, when I talk about 3 grams, and we know that we are currently, a lot of people are using 2 grams 8 hourly, or the dose is 6 grams, which is more important. How do you correlate this study in the context of patients who are given a higher dose of the drug?
Yeah, very pertinent point. I think they have kept it 1 gram thrice a day or 3 grams over 24 hours to make the protocol simple. But yes, obviously, if it would have been per kg, then it would have been better, because I don't know what is the weight of these patients, but in my practice, when I use more of a when I'm more lured to use more of an infusion, I give a higher bolus dose in infusion, and I use a much higher total dose of the drug, as you mentioned, maybe 6 or something closer to that. And as Sulagna also mentioned in his article, that I forgot, some review article has mentioned that this is probably more relevant in patients where we are getting bacteria where MIC levels are slightly higher, not in the very resistant range, but slightly higher, where the continuous infusion will be more useful. And because we have given it over such a all kind of patients, maybe, and that too has become underpowered because 2 things have been looked at. So we didn't get a appropriate outcome.
Ajit,
just to add, Anirban,
yes.
Just add to those comments. I think the authors do mention that the doses were changed in many patients and even therapeutic drug monitoring was not done. So that possibly answers, which means authors do acknowledge that dosing possibly might have been an issue.
Yes, the dosing was altered as per the physician's discretion in spite of that. Third important thing, Ajit, in these patients, from admission to randomization or from ICU admission to randomization, that is around 11 days, 9 to 11 days in each group and 5 to 6 days for ICU. Now, during which time the patient might have received under other antibiotics. It is very difficult to assume that the patients with sepsis have not received antibiotics, besides the point that large number of patients had received multiple antibiotics within the past 90 days. How do you take that in the context of understanding the efficacy and safety of meropenem infusion?
So the very fact that the patient received, patient might have received a lot of antibiotics within the last, many patients, up to 1/3 of the patients, in the last 90 days. and even before randomization, because that also can have some definite impact on the drug resistant pattern. That is for sure. Because here the composite outcome is about the PDR and XTR organism, because once the patient receives another antibiotic, obviously that can have some influence depending on the individual patient and the antibody can have some influence on the drug resistance pattern as well.
Just to add, Anirban, I think they've
Yes.
used combinations during treatment. And as you see, if you see the list of organisms, there are a lot of gram positives also.
Yes.
Isn't it, Dr. Sulagna? You have any comments? Because there were 20 to 25%, I think, were gram positive from what I see. I think there was one which said coagulase negative was present in 50%.
But unless there is an MRSA, I don't think we need to bother, isn't it? I mean, gram positive, most of the gram positive, except for MRSA, predominantly for.
Exactly. What is even more important, Ajit, and I will come back to Pradeep on that. When we are talking about these organisms, why didn't the authors find out the microbiological cure as it is the clinical cure? And how important is this to neglect this microbiological cure when you are interpreting the effect of an efficacy of a drug, which has been continued for a period as long as 11 days? Yes, Pradeep, you are muted.
Absolutely, Anirban. In fact, all the questions you're asking, the authors have mentioned actually in the discussion. They acknowledge in limitations, if you say they have acknowledged that any study of this nature, you would expect them to look at microbiological cure rates, because that really reflects, although the authors substantiate by saying since the clinical cure rate was looked at, they felt it was unimportant to look into microbiological, but they do mention that this is something one should have looked at, because any such antibiotic study, one would look at clinical cure rate and microbiological cure rate, which was not looked into this. It was terribly important, more so when they're looking at emergence of XTR or PDR organisms in this particular case. Chandrashish, your thoughts?
Yeah,
Yes,
I found it very a little bit strange that 50% of the gram positives were staff, coag negative staff. I mean, why should there be so much of coag negative staff if you? I'm sure they were not dealing with an epidemic of endocarditis. So why? I mean, these should be contaminants. So why was so much of contaminants? Was there a problem with the collection of blood?
And also you have to remember that all of these patients were immunocompetent.
Yes.
And Anirban, another important thing which possibly I would wish to highlight is this study was done under 4 very diverse countries. Italy, where we know the resistance patterns can be very different. Russia, I don't know what is the pattern. None of us know what are the microbiological patterns there. And then Kazakhstan, none of us possibly know, and Croatia. So they are very uniquely different countries. I don't know if that adds to the strength of the study or it would negate certain, resistance patterns.
That increases the external validity of the study, because whenever in all the clinical trials, we know the internal validity, though strong, the external validity is the limiting factor, because the study becomes inapplicable to the vast majority of the patients who don't satisfy all the inclusion criteria. And here, because we have 4 different geographic regions, and so whatever the results are translatable to all those patients of the different geographical regions, provided they satisfy the inclusion criteria. So I think that is one way it should be considered as a strength rather than weakness. I also want to invite, can we include Dr. Supradeep Ghosh? He is there in the list of attendees. He had some very interesting questions.
He was invited, I was told. Supradeep, maybe you can just
message him. Dr. Ghosh, if you are there, you have been sent an invitation. Can you please join using the, if he is upgraded, he can join. He had some important pointers to mention. But what is important in this study is also the fact that this study was carried out between the period of 18 to 21. Is it right? Its enrollment, it started. So when
yes, 18 to 22.
Yeah. 18 to 22.
So do you think that during this period of time for an organism like Klebsiella or E. coli or Pseudomonas, which is showing so much of variation even within a span of 3 to 6 months, can undergo a significant shift or a drift kind of nature as far as sensitivity is, as far as it is concerned, susceptibility is concerned? Yes, Chandrashish.
There's obviously
you're logged into 2 things. You can log out from one of the things, because otherwise it will buzz. Yeah.
Yeah, Dr. Anirban, Yeah, there's obviously a possibility that the sensitivity patterns could have changed. In fact, as we know, as Dr. Agappa was also saying, I really don't know what's the kind of bugs they deal with in Russia or Kazakhstan. But Italy, you all obviously know there are a lot of publications with this gram-negative multi-drug resistant bacteria. And in my ICU, and maybe in most of your ICUs with the hospital-acquired infections, an empirical choice of carbapenem, if I do, I mean, the antibiograms would say that most of I'll be probably right in 18% of the time, 18% of the time. So if I assume that a very similar kind of antibiogram is existing in Italy or similar countries, then I don't know whether I give carbapenem in whatever dose or infusion, whether it is going to change my outcome. Because if you look at the mortality of these hospital-acquired infections patients, it's very high. The mortality is almost to the tune of 40%, or how much was it?
They mention it as 31%, and the
31%.
authors do mention 31% for that SOFA score was higher compared to one of the reference study where it was 23%.
Absolutely, absolutely, the Lipman study. I move on to Dr. Ghosh before that. Dr. Ghosh, from whatever you have heard from other panelists and whatever you have read in the context of this study, what are the two immediate points that matters most while interpreting the observations?
I think the study is grossly underpowered. This is my first thing, because
that we have discussed.
But there are two reasons why it is underpowered. One, expectation of 12% difference in the primary outcome is too much of an expectation from. And second is, we need to consider that 30% of the patients had carbapenemase resistance, and another 20% did not grow anything. That means you can rule out, you can actually get rid of these 50%. So actually, we have studied only 300 patients. We have studied only 300. This is making it more underpowered. Second thing, this composite outcome business is giving importance to mortality and resistance development equal weightage is not a very scientific thing. So, that's the reason I don't think for a clinician, what we are interested in whether we'll adapt the study result to our practice. I don't think the study is good enough so that to change our practice in this. And regarding, I was just thinking about Robert Pradeep. I think the businesses in Russia and Kazakhstan is too shoddy. I don't know what practice is going on.
I'm sure, Ghojda, that applies to all of us. We all will probably think many times before stopping the continuous
trial. If they
yes, I'm coming to JP. I am coming to JP. JP, in 2 minutes, what are your interpretations on the strengths and weaknesses of this study? Yes, JP. Jay Prakash.
Yes, sir.
Your time starts.
I think that once they started their multi-centric trial, that means already they formed the protocol, and that is RCT. So they already formed their protocol, and accordingly they proceeded that. So you can't think that there are so many differences in their trial. One thing. Second thing, that sir, if you look at still, because in after reading that whole study, I found that because how many cases of MDR, it was not, we were not aware in that study. One thing, and one question from my side, I would like to ask from you people, that suppose that still whether we should proceed with that short-term therapy or long-term therapy. What is your personal experience? Please elaborate that one.
Well, definitely, JP, the long-term or short-term therapy depends upon the follow-up and which people monitor by clinically as well as through biomarkers and decide the course of the treatment. And in that case, it was 11 days, in which case they didn't know that. But yes, Dr. Pradeep,
just to add to what JP has said, I think it's an important point what JP is raising, Anirban, that 11 days is too long a time in some sensitive bug with a focused antibiotic usage. That is one point. The second point, again, that adds on to JP's point is, why use so much of combination? They have used a lot of combination, and we know to curtail antibiotic resistance and to adopt sound principles of stewardship program, we need to have a focused one antibiotic. Here they have used multiple antibiotics and 11 days, I'm sure, thanks Supradeep and JP for joining in. Supradeep also would agree 11 days is too long a time. And now the stewardship guideline is all about 4Ds, adopting
Yes.
duration, dosage, and narrowing the spectrum of usage of antibiotic and de-escalating.
But you
Obviously, there's
are
no
right,
mention
Pradeep.
of
Well, Pradeep, you are
de-escalation and
right.
so on
You
and
are
so
right.
forth.
But it may be so that their patients were growing multiple bugs, and for all the bugs, the meropenem was not the answer.
I just want to make a point here that I think Dr. Sulagna mentioned in one of her slides that the antibiotic stopping criteria for these patients, which was the criteria that they used, is if they were isolating Pseudomonas, then at least 15 days. For any pathogen where the MIC was between 1 and 2, then 15 days, and MIC less than 1, 8 days. And for patients without microbiology confirmed diagnosis, 8 days of treatment, and stopping antibiotic 48 to 72 hours if the core temperature was less than 38.4. So I think the median came around 11. But I don't know what is the percentage, but maybe they were dealing with more with Pseudomonas plus Klebsiella, where the MIC was between 1 and 2. So that's why the median came. But the range is from 8 days to, I think, 21 or how much, I forgot.
So that's the thing. So this study, this study, can you hear me? Yeah, that's fine. This study initially, some 900 that Dr. Ghosh was telling, initially the 900 patients were there. After screening, it became around 600. And you're dealing with 300 and 300, and around 50% has been lost. So see, coming to the antibiotic resistance, actually, with this current data, I know it's very difficult to it failed to make a difference between the infusion group and the bolus group, bolus administration. But the antibiotic resistance also depends on the number of exposures, isn't it? Because this is only one exposure. We don't know, because this is only 28 days you are following. 28th day, how much resistance is happening. So this may not be happening. If the patient is, for example, this has excluded all the immunocompromised patients, HIV positive patients, all that. So those kind of patients require it for a prolonged time. When the exposure is multiple times, obviously the antibiotic resistance pattern also can change. Because here we are dealing only with 28 days, isn't it?
See, 28 days we are saying in the context of the study, but yet we don't know that these patients, many of them have received for long periods of time during the past 90 days. Even patients might have received at 10, 12 days more, who knows? So the current
we are unable to, we can't say, yes.
That we are unable to be, because we don't have the detailed history of the antibiotic usage prior to that randomization or prior to admission, so to say. And therefore, it is very difficult, because that explains why, when we know that the basic principle to avoid development of resistance, we need to avoid crests and troughs. And that is best assured by the administration of continuous infusion. And when a study fails to find that out after doing it over a period of such a long time, then obviously the question arises that what was the reason why such obvious salient truth of PKPD principle could not be demonstrated. And that's what we are trying to seek in our answer from. So Pradeep, in the context of this study, I can assume that none of us would going to stop the usage of continuous administration of a. But when it comes to a study on the basis of meropenem, do you think it has applicability in other beta-lactams? Or in other beta-lactams, again, you go by their own principles and should not interfere or infer much on the basis of these observations?
I think Supradeep comments will take. I think Supradeep was meant to mention on the comments made.
Okay, Dr. Ghosh, what about its implications on interpreting other beta-lactams usage in the same form?
I think the PKPD principles remain same. There are this Dr. Sulagna mentions about certain parameters that why meropenem is different from the things. That's the reason it is specified that meropenem can be given for so many hours. I just want to mention two more things for the postgraduate. It is not only the temperature, it is a dilution. How much fluid you are using for dilution. Dilution is important. The temperature is important, and which fluid you are using for dilution itself, whether it is a dextrose or a saline. All these things makes a difference regarding the stability of the compound. Once we have decided this compound is stable for so many hours in this dilution, then I think this study result, or if this is applicable to all beta-lactam antibiotics, whoever is following the concentration dependent pattern.
So we will go to the last comment
I mean,
from
time
all the
dependent.
panelists. We will go to the last comments because we have already finished our time. I will start with Jai Prakash. JP, first to you. Please give in 1 minute your final conclusion of this Mercy trial. Jai Prakash is busy on phone. Jai Prakash, you are back. In 1 minute, you are muted. You are muted. We can't hear you.
Yeah.
1 minute.
First, I would like to say that Dr. Sulagna presented very nicely. One
We are
more,
talking
because
about the
whatever
trial.
trial you have given to her, she presented. She can't change any other. She has to only impress that what they studied and what was the interpretation and the result. All those things, it was very excellent. One more thing I would like to ask you people, because this is most of the time we have seen.
You need not ask. You give your final take-home message from Mercy trial.
Sir, that's why I'm coming to on that topic. Suppose that if a patient is land up in your ICU and just after 1 or 2 days of treatment, you will always find that patient there is acute renal insult. In that cases, what you will do? Whether you will go
That
for
is a too difficult question to be answered in 1 minute. I move on to Ajit. In 1 minute, please give your take-home message from the Mercy trial. Yes.
So people are doing the people are doing
trial.
Yes, people are continue to use the infusion method. They can continue to use the infusion, continuous administration. Other people who are doing the bolus, they can continue with the bolus based on the current evidence.
You go as you like kind of a situation. Let the people do whatever they are comfortable with, whatever they like.
At this point of time, unfortunately, the translation has not been proved. That doesn't mean that it is not going to be proved in the future. But based on the current evidence, people have to continue the way they are doing.
Perfect. Chandrashish, your final message from after listening, after reading everything about the trial. 1 minute.
My final message is this is a trial which is not going to change the usual practice of in whichever side you are a believer. If you are a believer of continuous, then you can. This trial proves that continuous infusion is as safe as intermittent. If you are a believer of intermittent, then this trial also proves that you can continue to do intermittent because it has not. It's again the outcomes are equal. In my practice, I will not follow the protocol that they have followed. I'll still change my protocol according to I mentioned already in which patients I think a larger bolus and a continuous will be useful, and I'll probably use a much higher dose. And in those patients in which I will probably stick to a simple regimen.
We accept your views. Dr. Ghosh. Dr. Ghosh.
I first of all, I have already informed that I am not going to change my practice. I think this study is grossly underpowered, and the study protocol has got a lot of limitations. And I just wonder if the study author's name were Pradeep Rangappa, Supradeep Ghosh, Anirban Home Chaudhary, Ajit Kumar, had the study ever been published in JAMA? I don't think so. It is only the Gore Chamre who would get published in JAMA.
Okay, probably that we are deviating from the main core context of the study. But anyways, I will go to Pradeep Rangappa for the last comments on this.
Thanks Anirban, and again thanks Sulagna for excellent presentation. So I look at it little differently. So when we look into the depth of these studies, so there is a lot of background data for all the listeners here. There are some 4 meta-analyses and there are 3 reasonably good randomized controlled trials which have shown there is a benefit in continuous infusion. I'm sure Supradeep, Anirban, you all agree. Any ID physician will vouch for this sort of a prolonged infusion, and we moved away. So I would look at the middle path because what I use currently is around 4 to 6 hours. We use it as an infusion. The reason which authors also mentioned, there's something called post-antibiotic effect, and which is significantly demonstrated in E. coli, Klebsiella, and Pseudomonas that lasts for 0.7 to around 2 hours after the administration of antibiotics. So we don't want that aspect with 1 hour infusion. So we want a prolonged infusion. But like as Sulagna said, there are a lot of limitations giving it over 24 hours. Maybe 4 to 6 hours as I'm practicing now seems reasonable at this point of time. And we should congratulate authors. They have put in a lot of effort against 4 countries with a diverse background. It's not easy to conduct such trials. So we have to give some due credit for conducting such a large scale. But I agree with Supradeep, there are a lot of limitations in this particular study, like any other randomized. Without limitations, we wouldn't be discussing this trial here. So on that note, I would take a middle path of 4 to 6 hours to stick to the scientific plausibility and a good sort of a hypothesis that we have with the background data on it.
So very well accepted. Lord Tennyson had said about this river that men may come and men may go, but I go on forever. So trials will come and go on forever. Dissections will continue. And we will be back with some new articles to dissect upon in our next episode of Rapid Journal Review. So wish everyone a very happy weekend. Thank you. Shubhratri, Shabar Khayat. Good night.
And nice to see Supradeep with Chandrayaan. So on that note, thanks Supradeep and JP for joining us.
Okay, and hope you are not planning to shift immediately.
Thank you, Dr. Anirban, Dr. Rangappa, Dr. Ajit for
Thank you.
Yeah, thank you all.
Good, yeah. We'll see you
Have a
soon.
great weekend.
Okay, good.
And
Wonderful
I
session.
congratulate the
And-
young doctor.
Thank you, sir.
Excellent presentation, Dr. Sulan. Excellent presentation.
Yeah,
Yes.
very nicely
you.
presented, Sulagna. I think this sends out a strong message as to how
And the
one should
congratulations
present.
should be shared also to convey to Chandrashish for
Yeah.
taking
Chandrashish.
the
Congrats.
moderation job and as a mentor and as her guide for preparing.
Thank you. I think
Anirban sir, don't
99%
stop
of
this.
the credit should be for Sulagna. I will only take 1% of it.
No, sir, without your help, it is not possible.
We should always continue this kind of session, sir. It's a
Thank you, JP.
Very good
Thank you.
session.
We'll answer your AKI.
Yes, JP has, as usual, has been vocal, but although he was missing up the mark by narrowly, but still he gave very good inputs on the subject. And I hope that he will be present again in our next episode.
yes,
JP,
Yes.
I hope you will be present.
yes,
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 yes.
definitely, always, sir.
So good night.
Thank you.
Thank
And
you. Thank
see
you
you
all.
again
Thank you all.
soon.
Yeah.
Shubhratri.
Thanks.
Bye.